Hey, BC here for BC Nephro. Thanks for watching. I'm Dr. Brian Cronin, board certified nephrologist and clinical specialist in hypertension. Anti-Glomerular basement membrane antibody disease, Goodpasture syndrome, pulmonary renal syndrome, rapidly progressive glomerulonephritis. What are these things? We're going to get into that. But first, make sure to check out bcnephro.com where there will be in-depth articles on this and other nephrology topics. Check out my Instagram at bcnephro and check out the other videos and shorts at this channel. Now, let's get into it. Anti-glomerular basement membrane disease, also referred to as anti-GBM antibody disease, is a small vessel vasculitis against capillaries in the kidney, glomeruli, and lungs alveoli. A autoantigen anti-GBM antibody is formed against a specific domain in type 4 collagen of the glomerular basement membrane of these capillaries, leading to kidney involvement, which is rapidly progressive glomerulonephritis, and lung involvement, which is alveolar hemorrhage. The majority of these cases, 80 to 90%, will have renal involvement. About 50% of the cases with renal involvement will also have lung involvement, and it is only rare that there is lung involvement without kidney involvement. When there is kidney and lung involvement, sometimes it is referred to as Goodpasture syndrome, which is one of the pulmonary renal syndromes. The other common pulmonary renal syndrome with rapidly progressive glomerulonephritis and alveolar hemorrhage is ANCA-associated vasculitis. So how and why does this happen? The hypothesis is there is an exposure to an environmental antigen, which results in the production of the autoantibody, anti-GBM antibody, in genetically susceptible individuals. There often is a prodromal respiratory infection, and there are certain HLA-DR subtypes that are associated with anti-GBM antibody disease. The other hypothesized factor is that there is some other condition that causes damage to the glomerular basement membrane, allowing the antigen in type 4 collagen to be exposed and therefore detected by the immune system. Although this is not always seen in the renal involvement RPGN, there is an association with ANCA-associated vasculitis and membranous nephropathy, which are certain kidney diseases, glomerulonephritis, which may cause concomitant GBM antibody disease by disruption of the basement membrane, and also may be an important factor for the alveolar hemorrhage, in which the lung damage can be from things like cigarette smoking or exposure to hydrocarbons. Now, hydrocarbons are things like gasoline, kerosene, paint thinner, things that we kind of instinctively know it's not good to breathe the fumes of. Now, this is a rare disease, incidence of about 1.5 per million. However, it comprises about 10% of the cases of rapidly progressive glomerulonephritis. It is an important condition to be aware of so it can be promptly diagnosed and treated because it is a very acute fulminant condition. Patients in whom treatment is not initiated promptly, the kidney failure may be irreversible. The renal presentation is a rapidly progressive glomerulonephritis with an increase in creatinine over days to weeks. This will be associated with a nephritic sediment, glomerular hematuria, and proteinuria. The diagnosis is made both serologically and by kidney biopsy. The anti-GBM antibodies can be detected. However, the problem with this is often a send-out test, and it takes some time for the results to get back. If there is a high index of suspicion of renal involvement, kidney biopsy should be pursued. The kidney biopsy is going to show crescents. Rapidly progressive glomerulonephritis is also referred to as crescentic glomerulonephritis, as there are often crescents associated with this. Given the acute fulminant nature, many of the glomeruli, in most patients, more than 50% of the glomeruli are affected with crescents, the average being 75%. Now, crescents are also seen in the other causes of rapidly progressive glomerulonephritis, like ANCA-associated vasculitis. The distinction is made by immunofluorescence. The immunofluorescence for this condition is going to show linear ribbon-like staining for immunoglobulin, typically IgG. The reason it is like this is because the antigen is in the glomerular basement membrane, so the antibody has uniform deposition. Other causes of immune complex kidney disease, the antigen antibody complex forms in the circulation and is deposited in the glomeruli. This gives a lumpy, bumpy, granular pattern on immunofluorescence. There are some cases that are referred to as a typical anti-GBM antibody disease. In these cases, the antibody is not detectable in the serum, but the renal pathology findings are found. These cases are typically a little bit less severe, less fulminant. Now, treatment. Prompt treatment is important, as if the patient is dialysis dependent and if all 100% of the glomeruli are involved, renal recovery is rare. Treatment is threefold: corticosteroids, plasmapheresis, and cytotoxic therapy. Steroids, initially pulse steroids followed by oral steroids, should be initiated when this disease is suspected while we're waiting for confirmation with the serology or biopsy. Once the diagnosis is made, plasmapheresis to rapidly lower the antibody is instituted. This typically should be done on a daily basis for 2 to 3 weeks until the antibody is undetectable, and the cytotoxic therapy is typically oral cyclophosphamide. Now, some suggest that if there is severe renal presentation, dialysis dependent, 100% of glomeruli affected, that the chance of renal recovery is so poor that the risk of immunosuppression are not warranted. In my opinion, unless there is some other contraindication, I would consider immunosuppression to prevent the development of alveolar hemorrhage at a later date, which can be life-threatening. Now, treatment typically only needs to be for 3 to 6 months. The antibody levels should be monitored to make sure they don't recur, but they typically do not recur. This is a disease that for some reason the body develops immunologic tolerance, the exception being if there's concomitant ANCA associated. There's a high incidence of ANCA associated, so in my opinion, if there's renal involvement, the anti-GBM and ANCA antibody should always be checked together. If there is ANCA involvement, there is a higher risk of relapse, but on the other hand, if there is ANCA involvement, there is a higher chance of renal recovery, even if the patient is dialysis dependent. So that's it. Thanks for watching. If you made it this far, you might as well hit like and subscribe, leave a comment, share this video with someone who you think may be interested in learning about this topic, and until next time.